my presentation visible?
Yes, sir.
Okay. Is everybody here?
Yes, sir. Most of the student and fellows have joined, sir.
Is my presentation visible, Manisha? Hello?
Yes, sir. Yes, sir. It's visible.
Yes, okay, we'll start. Okay.
Yes.
So this purpose of this class is to not to teach you people each type of and each and every type of anterior uveitis, but the presentation is to how to approach to the anterior uveitis and how to make a diagnosis for a patient and how to identify the treatable cause of that patient, and also to differentiate other form of the uveitis from the anterior uveitis and to order the particular test to the patients. So this is the basic idea I am giving you people to how to see the patients in the OPD and what to look for in the OPD. Okay, so there is one question I am going to ask you. This is a 30-year-old male present with the recurrent non-granulomatous anterior uveitis in left eye. Which of the following test will you order for that patient? Anyone wants to give the
ANA,
answer?
ANA, ANA, sir.
Okay.
And
Any?
RA?
Okay.
No.
Anyone?
Sir, HLA typing is also like important, sir, apart
Okay.
from RA factor and ANA, because that age group, most common is ankylosing spondylitis. You have to rule out in such age group patients.
So at the end of the presentation, we'll see the right answer. Okay. So there is a standardization of the uveitis nomenclature, that is a Sun criteria, which is for the how you the uveitis course of the uveitis, that is it is acute, recurrent, or chronic. So basically, acute anterior uveitis is sudden in onset and limited duration, that we call uh, acute anterior uveitis. So after acute anterior, there is a recurrent anterior uveitis, which has a repeated episode, but there is inactivity in between more than 3 months. Okay. And the chronic one is the persistent type of the anterior uveitis, which is relapsing again, but there is no inactivity period more than 3 months. Usually, as soon as you discontinue the treatment, the relapse will occur. So, based on the etiology, there are infectious types of anterior uveitis, autoimmune types of anterior uveitis, and masquerades also. Okay. So, there is a clinical pattern recognition in every type of the uveitis. You have to do a clinical pattern recognition before you decide which type of uveitis, what is its cause and all. So for anterior uveitis, there are simple three questions you have to ask yourself before diagnosing anterior uveitis. First of all, you confirm that is the anterior uveitis only. So for that, you have to do a dilated examination before dilating a patient. Confirming anterior uveitis is usually mistaken, because sometimes you treat as anterior uveitis and patient is not resolving the uveitis. So after you diagnosis as the intermediate uveitis or posterior uveitis, so it's always do a dilated examination before giving label it as the anterior uveitis. Second step to do is look for the granulomatous keratic precipitates. If there is granulomatous keratic precipitates, then definitely it is a granulomatous disease. Then you have to rule out the TB, sarcoid, and viral causes such as HSV, VZV, CMV, and pan-uveitis cases like VKH. Okay, you can someone tell me what are the other causes of a granulomatous keratic precipitates? Manisha, other than leakage, TB, sarcoid.
Leprosy, sir.
Okay. Next.
And
Sir, primary
sympathetic
symptoms.
ophthalmia.
Primary
Sympathetic
symptoms.
ophthalmia.
Yes, sympathetic ophthalmia also. Okay. Then, if your patient doesn't have a granulomatous keratic precipitates, then what? So look for a non-granulomatous. In absence of a granulomatous, look for the non-granulomatous keratic precipitates. If the non-granulomatous keratic precipitates or KPs are there, then the one simple question you have to ask is a inflammatory joint pain, not joint pain, but the inflammatory joint pain. Then that patient must be having a HLA B27. Okay. So coming to non-granulomatous, we'll see the first non-granulomatous keratic precipitated patient with the usually these patients present with the acute onset of the uveitis. Okay, they so patient came to you, you saw the patient, it is a non-granulomatous KPs. So what you ask, you ask the it is acute onset or not. Most of the patient have a acute onset of a disease. So tell me what are the signs and symptoms of the anterior uveitis that you are looking for.
Congestion.
Sir, anterior, circumciliary congestion.
Okay.
Photophobia, sir.
Yes.
Anterior
Pain
reaction, sales and flare,
Okay.
and pain, sir.
and
Okay.
pain. And also photophobia, sir.
Sir, there is myotic pupil.
Yes, myotic pupil.
Yeah.
What are the causes for photophobia?
Sir, there is ciliary spasm.
Yes, definitely ciliary spasm. So next question you are asking is it is a unilateral, it is happening only in one eye or it is alternating sometimes in right eye, sometimes in left eye, or it is a recurrent. Okay. Then next question is about the inflammatory joint pains. Typically patient will say it is a very excessive in the morning, in the very early morning, even in the 3 o'clock, 4 o'clock, or as the day passes it will resolve. So again, one very important thing to look for is a fibrin or hypopyon in the antecedent. That will also lead you to the particular diagnosis. And definitely look for the posterior segment before the moving forward. So when your patient came to you, you ask him it is a unilateral or recurrent anterior uveitis. Then you move to the what is the cause for that anterior uveitis. So very few patient with you see the HLA, you do the HLA and the HLA positive alone come positive, but patient doesn't have a symptoms, any systemic symptoms. So you we have a HLA associated uveitis class. So most of the people, even me, in my beginning of the fellowship, I usually ask about the inflammatory joint pain only. So patients with acute anterior uveitis non-granulomatous, you ask for the joint pain, but what else other than a joint pain you are asking? Okay. So tell me the signs or symptoms. What are the leading questions you are going to ask when the patients of ankylosing, you are suspecting the ankylosing spondylitis to the
Sir,
patient? So what are the yes,
uh, sacroiliac joint pain.
Sacroiliac joint pain.
Young
And
patient.
yes,
Young
morning
patient.
stiffness
morning
and low back pain.
low back pain.
Sir, and on X-ray that bamboo spine appearance.
Yes. So if you are suspecting the ankylosing spondylitis, so you are ordering the test HLA-B27 as well as X-ray spine. Okay,
Yes, sir.
that's the, okay. Then tell me the reactive arthritis patient. What are the signs or what are the symptoms of reactive arthritis patient have other than a uveitis? What is the triad of reactive arthritis?
Conjunctivitis,
Uh,
arthritis.
and
Urethritis
also
and
urethritis, sir.
arthritis.
Yes.
Urethritis.
So what will you ask for the patient?
So burning micturition or
Yes,
and
that is the one of the most important question for the patient to ask. Not only the joint pains, but also a burning micturition. Okay, next. For the psoriatic arthritis, what will you ask for the psoriatic, or what will you look for the psoriatic arthritis?
sir, any skin
Skin
lesions,
changes,
Changes.
skin
skin
lesions.
changes for
Yes.
of the
Which
psoriasis.
skin lesions, or which part of the skin lesion, which part of the body the
The
skin
At
lesion?
dorsum of the
joints.
so dorsum of the hands and the anterior surface of the leg.
Yes. So the patients with the psoriatic arthritis have a psoriasis, means see for the look for the psoriatic patches. Okay. So for the inflammatory bowel syndrome, what will you ask? Or which syndrome having the association with the uveitis?
Crohn's ulcerative
Crohn's
colitis.
Dysentery
and
or
Crohn's
altered bowel
syndrome, sir.
habits.
And
So, okay. So, patients with HL, so these all patients have a HLA-B27 positivity along with the different signs and symptoms. Not only the back pain or not only the inflammatory joint pain is associated with HLA-B27, but these reactive arthritis, psoriatic arthritis, inflammatory bowel syndrome, and undifferentiated some spondyloarthropathies, like they can't tell you the which multiple you can fit that in any of above is the undifferentiated. So always remember, not the inflammatory joint pain is only associated with the HLA-B27, but these are the other things too. Okay. So coming to other than HLA-B27, what are the next causes for the acute anterior non-granulomatous uveitis? So we'll see the juvenile idiopathic arthritis later. First of all, tell me the what is the signs and symptoms of Behçet disease?
sir, oral ulcers.
Okay.
Ulcer.
Ulcer. Skin changes.
Yes. What are the signs Behçet disease as presents? What is
Sir,
the typical?
hypopion is classified.
Yes. And what is the hypopion typical of?
The
Typically,
Shifting hypopion.
yes, shifting hypopion.
Shifting.
So next, okay, that is best. But what are the what you ask basically? You see this, but what about the ulcers?
Oral recurrent abscess ulcer.
Yes,
oral.
oral. So one of the leading question to be asked in an acute non-granulomatous uveitis is about oral ulcers. Okay, to rule out batches, because it is very common. Batches disease is much common than you think. So definitely ask for the non-painful oral ulcer, which is usually 3 to 4 times in a month, lasting for 4 to 5 days. Okay,
So is it non-painful or painful?
it is non-painful usually, but sometimes it painful, but usually non-painful. The large ulcers will non-pain, usually non large one is the painful sometimes, but usually non-painful, and it will, even patient said it will gone by automatically or not leaving any scar or anything.
So even genital ulcers will be non-painful
Yeah,
or
yes. Balanitis patients present with the balanitis also. Okay.
okay.
So moving to the next, the tubulointerstitial nephritis and uveitis. So these are usually patients present with the, sometimes I have never seen the Tinu syndrome patient, but usually patient present with the acute onset of a bilateral non-granulomatous uveitis that is very recurrent, and patient might be the NSAIDs addict. So that might be the one of the case the patient is taking the NSAIDs, and that leads to the uveitis. Again, for the Kawasaki disease, majorly children and adolescents are present with the cervical lymph node and typically strawberry tongue, erythema, and you may see the rashes in the Kawasaki patient, but it's not ki Kawasaki uh, is present in any stage of the disease. Okay. Tell me the lens-induced uveitis. What are the signs and symptoms you see in the lens? Usually signs of the lens-induced uveitis. Alind?
Yes, sir. It can be phacoanaphylactics or phacogenic or a phacolytic glaucoma. So it present with the pain, circumciliary congestion, and corneal edema. And patient had a cataractus changes, cataractus lenses. In case of the phacoanaphylactic, the lens matter are having the immunogenic reaction, and that complex will lead to the anaphylactic attack and causes the uveitis.
Okay. So usually hypermature cataract, you see the hypermature or traumatic cataract that leads to simply lens-induced uveitis. There is a history of trauma. And what are the medications that leads to the uveitis? Some systemic
Sir,
medications and topical.
Antibiotics
sir,
is
topical
sulfonamide.
prostaglandins, sir, commonly.
Yes.
And beta
Glucagon.
blockers also has been noted, and systemic like antivirals, sir. I don't know specifically which antiviral, but antiviral medication.
Yes,
Cidofovir
Cidofovir is
antivirus
one of the most
mostly.
common. Rifabutin is most common. That is,
80.
and sulfonamides. Similarly, the Tinu patient also had a NSAIDs induced uveitis. Okay, in traumatic uveitis, yes, you have a blunt trauma, so you have to. So coming to the juvenile idiopathic arthritis, which is the one of the most important uh, to diagnose, but the patients with the JIA is usually came to us with the diagnosis only. Okay, so we rarely do a diagnosis of a JIA and then send to the rheumatologist, but there is usually patient came from the rheumatologist. They have a JIA already diagnosed, and the patient now patient's complaint is loss of a vision. Usually these patients don't come with the pain, ciliary congestion, because these patients are very mild reaction or mild anterior uveitis, but that is a chronically. You can see here there is a BSK in all the three patients, BSK with the occlusive pupillae, seclusive pupillae, as well as the cyclitic membrane also you can see. Though, so our job is to tell the or rheumatologist or the treating physician that it is a high risk or low risk juvenile idiopathic arthritis. So the follow-up should be how much frequently you should do. So this the criteria I mentioned here is a young female with anti-nuclear antibody positive patient came to us with RA factor negative or oligoarthritis onset. These are the female patients you came to you for the cataract surgery. Okay, so these are the high risk patient, and these should be followed every 3 to 4 monthly because the reaction is not much in these patients. Okay, so tell me what you do investigations in this patient before the cataract surgery. What are the risk factor for the cataract surgery? How you proceed these patients with the cataract surgery? If these patients come to you, what are the investigation will you do? Shishir?
Sir, since these are young patient, we have to do complete this thing blood count as well as this anti nuclear ANA, ANCA, C ANCA, P ANCA, these test ESR, CRP, everything we have to do because if there is a active inflammation, then we have to suppress it with steroids or immunomodulators. Along with rheumatologist, we can start on steroids and immunosuppressants. And once the inflammation is well controlled, then it is better to proceed with surgery, sir. Or else it might surgery might again worsen the inflammation and
Which
causes more damage.
investigation you will do in this case?
Posterior segment evaluation, UBM.
Yes, UBM. Why you want to do a UBM in these patients?
So we want to see the ciliary processes. Like if
Yes.
we do the surgery, then it can lead to ciliary shunt. So before that, we have to see the
So
status of
UBM
the.
is very important in these patients because there is a this is a chronic type of a uveitis. So there is a cyclitic membrane atrophy of the ciliary body is already present. So when you do a cataract surgery, there is very much chance to patient go into the phthisis. Okay, so sometimes patients say ki, because of the surgery it went to the phthisis, but it is usually the cyclitic membrane, or you have to do the membranectomy also sometimes to save the eye. And usually these patients don't respond to the oral steroids, so you have to start these patients with the methotrexate, azathioprine, cyclosporine, mycophenolate. These are the drugs these patients usually need. So one
Sir,
of the
sir,
yes, yes.
so that juvenile arthritis is the contraindication for putting PCIOL.
No, this is not contraindicated for putting PCIOL because it is going to, but the surgery is complicated surgery, and even if you do a good surgery and there is a cyclitic membranes all over the 360, or suppose there is ciliary shutdown, already ciliary shutdown, so this might lead to a thysical eye post surgery, even
Yeah,
if it's a good surgery.
because I've read, sir, ki we should not put PCIOL in GI.
Okay, I have to read about that. matlab, I don't know exactly. Might sir might know better.
Okay, sir.
Sir, like
Okay.
how to diagnose like ciliary shutdown? Like by in UBM, what actually we need to look for?
Uh,
Like
you in UBM you have to do all 360-degree UBM to see the ciliary
uh,
processes. You actually normally see the ciliary processes and UBM that are
okay,
sharp things, usually sharp ciliary processes. But after a UBM, sorry, after a usually atrophy of the ciliary, they like look like a flat, usually flat, or the
hmm,
membrane over it. This is usually seen in the UBM only, not on the B scan.
okay.
Do we have to look for the ciliary processes also, sir? Is there an atrophy
Yeah,
of those?
yeah, sure, sure. This actually you can see the ciliary processes on the UBM.
Sir, if it is there, then we should like do surgery or not
Yeah,
like
yeah,
that.
yeah. You should do a surgery if there is ciliary process. Check the IOP also before the
Okay.
doing surgery.
So when we diagnose a newly case of GI, how oftenly we have to call the patient for follow-up?
Depending upon because this patient don't have a pain and redness as much as other patient. So if the patient is high risk, every 3 to 4 months. If patient is moderate risk, every 6 months. And very low risk patients have a yearly follow-up.
Okay, sir.
Sir, it's called as uveitis with white eye. Why there is no congestion?
Because that is usually less reaction.
Okay.
Sales and flare is usually less. That's it, no irritations. That's why there is white eye.
Is there any other cause of uveitis with white eye? Or
Yes, yes,
it,
yes.
okay.
There is a CMV or Fuchs
Or
uveitis. You have
Fuchs uveitis.
Few.
uveitis. PSS. You have PSS where you can find the
White eye.
okay.
Sir, even
So
Bessett's also white eye
Batch.
only.
yeah, it's also white eye. So there are few when you see the hypopyon, you can there are few causes of the hypopyon. You have to look for the HLB27, Behçet's, rifabutin, and there is acute leukemia also, myeloid leukemia and acute lymphocytic leukemia. These are also present with the hypopyon. Not only because most of the time we see the HLB27 is only the most of the time present with the hypopyon, but not like that. You have to ask other causes also. Okay. Then moving forward to the granulomatous, what will you do when you saw the granulomatous KPs? There are mutton fat KPs or the fine granulomatous KP. You have to decide. With the mutton fat KPs, there is actually a volume of the KP. That means these are not only flat KPs, but they have the breadth and width also. So they are 3D and they are not flat. So you can easily identify that mutton fat KPs. They are actually large. How does it help to differentiate granulomatous KP? Because we rule out the non, whatever we have learned, we have to rule out that for the non-granulomatous causes and lead and go towards the specific cause of the granulomatous KPs. Okay, so there are these are the few uh, these pictures have a mutton fat KPs. You can see one of the most common causes is TB sarcoid, and these are the fine granulomatous KPs where HSV, VZV, CMV are the one of the major causes for the fine granulomatous KP. These are the not only, but I have mentioned these as these are most common. Okay, you can look for the nodules also, Copies nodules and Busaka nodules. So how to one of this here one of the thing is how to differentiate it is HSV, VZV or CMV. The one of the few things here I have mentioned one chart also to how to differentiate between these viruses. These are the acutely present granulomatous keratic precipitates. The HSV has where is HSO, HZO also. Yeah, previously herpetic keratitis. You can see the signs and symptoms of the old herpetic keratitis. Then look for the iris atrophy. Both HSV and VZV present with the iris atrophy. D-shaped without dilatation the pupil. You can see the D-shaped pupil. There is iris atrophy. And very important thing to look for is the IOP of the patient. Okay. So the if the patients with the granulomatous acute presents with the IOP around the 40s, there must be a diagnosis of a viral keratitis or viral uveitis. So tell me what the clinical test you can do in these patients. To what are the different tests you can do? What test you do in the
PCR,
yes
PCR.
Viral assay
uh,
or PCR.
clinical on slit lamps on your OPD.
Sir,
Same.
most these cases na they
Sensation.
have keratouveitis, sir. Like corneal involvement is also common, so we have to always stain and look for any corneal involvement,
Yes.
like
First
dendritic
thing to do,
pattern.
even if
Uh,
you see the KPs, don't forget to see the anterior cornea. Okay. Then what else?
Have to correlate with the lesions, sir, on the face for herpes.
Look for the old
Corneal
lesions.
sensations.
Yes, very important.
Vesicles.
Corneal sensations. Okay, you definitely miss the corneal sensations. So usually clinically VZV HSV usually present the similarly, patients present similarly, but other hand the CMV patients have different profile than the HSV or VZV. The CMV patients have a granulomatous KP which are the typically coin shape, sometimes pigmented, most of the times non-pigmented. The difference of IOP is usually a huge because the CMU patients usually present with the 50s IOP, not less than 40s, is usually 50s. But the reaction and the IOP doesn't match because the reaction is usually mild, but IOP rise is high, is seen in the CMU patient. Typically, the differential diagnosis for CMU is the Posner-Schlossman syndrome and Fuchs syndrome. Okay, because these patients also have a mild reaction and a high IOP. So, tell me what are the signs and symptoms of a Fuchs and how will you diagnose the Fuchs?
Pukes,
Sir,
sir, there will be no
unilateral.
posterior
Just
synechiae.
one, one, one by one.
One is
Stellate KP,
head.
sir.
Sir, it is a chronic unilateral uveitis. It is a non-granulomatous uveitis with stellate KPs and
Mhm.
most commonly in a young female.
Yes.
Also, there will be no involvement of the posterior segment. There will be no posterior synechiae also, and no CME in future. Also, AC reaction will be very less, only 1 plus, and in later in future, IOP will be raised.
Yes.
Sir, and one more
Sir.
thing is those KPs are not located inferiorly in the arch triangle. It will be
Yes.
distributed in the
So,
diffuse manner, and there might be presence of anterior vitreous cells also. It's not
yes.
like vitreous will be completely this thing. And other important thing is these patients are very prone to develop PSC cataract.
Yes, yes. So these patient, even post cataract surgery, the patient have most of the patient have a floaters, complaining of a floaters and all, because the reaction posterior segment also there is involvement. And what about Postman-Schwarzman syndrome?
Glaucomatic crisis, sir. The patient has a high IOP,
Yes.
and
It is not correlating with the anterior segment
Yes.
inflammation.
Similarly,
Inflammation is very
CMV.
less, but IOP is so high.
Yes.
Recurrent IP raise, sir.
Yes. Recurrent raise.
Uh, because it causes severe trabeculitis, sir. That is the
Yeah.
reason why they have very high
So
IOP.
for high IOP, that's why I mentioned all three here, because the CMV, Postman-Schwarzman, and Fuchs present with the high IOP. Okay, so you have to differentiate in between them. So these are the, you can take a screenshot, or this is in the article also. The main thing here to look for the reaction, which is a mild in CMV, IOP is high, the medium large coin shaped KPs, which is not IOP is not correlated with the inflammation, and pupil is most of the time round, not the atrophy or D-shaped pupil like HSV or VZV. Okay, so coming to TB and sarcoid, which is the one of the most common causes. So for TB, for sarcoid TB, don't just look for the anterior segment. Always look for the posterior segment, because this TB patient, leprosy patient, all granulomatous patients will have something in the posterior segment, something or not. Most of the time, this present with the pan uveitis, intermediate uveitis, posterior uveitis, not only anterior uveitis. So any you are looking for the TB, ask for the TB contact, weight loss, fever, cough, history of seizures. Also, you have to ask for the neuro TB. Check for the lymphadenopathy if anything patient said he has any swelling over the body. Do a Montu, always do a Montu test. Nowadays, it is very rarely, if the patient present with the granulomatous uveitis, please do a HRCT chest rather than a X-ray, because most of the time to rule out the sarcoid or TB, you have to again do the HRCT chest. So in in TB patient, always do a HRCT, or any any granulomatous anterior uveitis you are suspecting, please do the HRCT chest. Okay, and any patients of a granulomatous uveitis, whether presents with any signs and symptoms, but there is a definitely a granulomatous anterior uveitis, please do a TPHA and VDRL, because the syphilis can present anything like anterior uveitis, posterior uveitis. And why to rule out the syphilis, and syphilis is very important in granulomatous uveitis patients. Hello.
Can you repeat the question, sir?
Why you should rule out syphilis before starting any treatment?
It's a
Sir,
greatest
because
masquerade
syphilis
Fast,
and this HIV and all these are very common,
fast
sir,
spreading.
especially in active male or females. So we have to rule out, because if we give steroid now, it will worsen the condition. So we have to always give the antiviral or related treatment, and then under that cover only we have to start steroids if you are planning to give steroids.
Yes.
These
And
immunosuppressives, it will worsen.
yes, and syphilis is much more common than we think, and it is one of the most treatable uveitis. Okay, so 14 days of antibiotic and your syphilis is gone. So it is very easily treatable, very easy to find out. So just TPHA and VDRL will have more sensitivity as well as specificity. So do both tests, not only TPH or not only VDRL, do both tests. Okay. So coming to the sarcoid, this is a anterior. It is not like ki sarcoid can present only as an anterior uveitis, but it is any type of bilateral chronic uveitis, not only anterior, but it is. So you I saw you, most of the people do a serum ACA levels or in any of the patients. So serum ACE levels are not specific to even sarcoid. So if you are suspecting a sarcoid, so do a multiple test. Okay, it's not like you just advise the serum ACE levels and that is raised or that is normal. That means you diagnose the sarcoid, because you have to do a chest X-ray to look for the chest X-ray or the chest CT to look the bilateral hilar lymphadenopathy, X-ray of the fingers for look for the cystic changes in the phalanges, as well as you have to do the serum ACE levels also. But serum ACE levels normal or elevated does not rule out any sarcoid. So when I'm reading these this picture, I found this picture, the true iris nodule in the sarcoid. These are the typically found in the angles. I have never seen these nodules, but yes, textbook mentions these are the typical iris nodule that present with the angle. They are very that later, when the treatment start, that will later form the pass. So these are the typical true iris nodules in sarcoidosis. Okay,
These
these are
patients will have skin nodules also.
yes, these patients
Maybe
have skin nodules also. So so you get the idea about how to differentiate between the, how to tailor the uh, approach of the uveitis patient. So coming to the first question again, so how, what is the correct answer for this patient? So which test you will advise for this 30-year-old male patient?
RA factor, sir. According.
Sir, ANM onto
But RA
VDRL.
factors are more is common in female, no?
So answer is, you
Hmm.
don't have to order any of these. You have to just order a HLA-B27 for this patient, because the answer is, because patient present with recurrent. I have told you ki recurrent non-granulomatous. VDRL Montu test is for the granulomatous. ANA RA factor is for the chronic tests. JIA.
Okay, sir.
Okay. So the basic idea about this class to order the test accordingly to the patients, not like ki every you order a battery of test, even every case of the acute anterior uveitis. For that reason, even you we usually, or the Kansky said ki don't order a test in a first episode of acute anterior uveitis. But when you saw the first episode of acute anterior uveitis, you go and ask these patients all these questions, where it is ankylosing spondylitis, reactive arthritis, psoriasis, and order the test according to the patient. Most of the time, if the patient doesn't have any positive, that might come to the idiopathic. But yes, usually even the first episode of acute anterior uveitis, with the posterior segment examination, you order the specific test according to the patient's need. Don't order a battery of tests in each and every patient. I saw most of the you, even first episode of acute anterior uveitis or recurrent acute anterior, you people order toxoplasma tests and reactive ANA tests and all rheumatoid RA factors and all chest X-rays. So usually don't order the such battery of the test. Just order the particular one or two tests according to the patient signs, symptoms, and which category it is a patient fitting into, the granulomatous, non-granulomatous, acute, chronic, and depending of, just order the test. Okay. And next class definitely we'll have a intermediate uveitis cases, so we'll again discuss the TB, sarcoid, leprosy, all these things. Okay.
Okay, sir.
Sir, one question. Shall we order ESR for acute or for recurrent? Or shall
So
we?
CBC you have to CBC ESR you have to order because of the inflammation. Is there actual some inflammation going on in the body? And the basic things to order is like CBC ESR along with the blood sugar, because if you needed the oral steroids, suppose there is a patient with the fibrin and with the topical only steroids, patient is not improving, so you have to start him on the oral steroids. So for oral steroids you have to order a blood sugar and blood pressure.
Okay, sir.
And for that oral steroid, you have to order CBC and ESR, because there is no, you have to rule out there is another focus of infection in the body. In that cases, the CBC ESR will have a deranged values. So not for the diagnosis, but for the treatment purpose.
Okay, sir.
Sir, I have a question.
Yes.
Dr.
Sir,
Akash? Okay.
Yes. Yes.
Continue.
Hello.
hello.
Dr. Akash, this is Bhavagna here. I have a doubt.
Yes.
So I want to know, why is there difference of presentation in KPs in varied conditions? Like we have Al's triangle, then a diffuse presentation in Fuchs, and the Krukenberg spindle that we have in pigment dispersion syndrome. Because everything is associated, as far as I know, is because of the aqueous currents that are going.
Yes.
But
Yes.
why is there a varied presentation like this?
For the diffuse presentation, we have a CMV, Fuchs, and uh, uh, PSS. These three things are usually diffuse, but rest of the, because of the currents only, they are presenting in the alt triangle.
uh, like why not in, why is then, why are we having a Krukenberg spindle? Like because Krukenberg spindle is usually from superior to inferior.
Yes. Yes.
So I mean, this was a doubt I genuinely have. Like why is that presentation varied in these two cases?
I think I have to read about the Krukenberg
Okay. Yeah.
spindles, and I'll get.
No, Krukenberg spindle, as far as I know, it is just the iris pigments which are deposited. I don't think there is a breakdown of blood aqueous
No,
barrier in
no.
that.
No, there
She's
is no
she's
breakdown of.
asking about the why they are deposited in the particular position only.
Okay. Okay.
Yeah, I
Can it be
think
because of the
it,
severity of the?
no, the main reason is Fuchs is considered most likely post-viral.
Yes,
So
the
it is more.
reason behind the Fuchs and PSS is a CMV. Usually, the viral is a CMV. So the pattern of the all the three is the similar pattern. Because the cause is mostly similar in these patients.
Oh,
Uh, Sir, I have a question.
Yes.
Sir,
Uh,
why there
yes. Yes.
so why there is a granulomatous uveitis in a primary syphilis, and in a secondary syphilis there will be a non-granulomatous uveitis?
Usually, in to be begin with the some granulomatous uveitis usually present with the non granulomatous also, but in later stages they are usually granulomatous
Okay, sir.
in a very early stage. And I want, sir, what about the IOL in the JIA? What is your stand on that? She's asking the choice of IOL in the JIA patients. Is Saurabh sir there?
Hello, I didn't hear.
Sir, the choice of IOL in the JIA patients according to.
Yeah, in very young patients with GI, I generally avoid putting IOL.
Okay.
So, but older patients where GI is more controlled and patient is under immunosuppressives, then IOL is not a problem. So
Okay.
typically, like after 10 years, I don't mind putting IOL, but if the child is very young, then it's better to keep the patient aphakic, because if we put IOL, sometimes there is very intense reaction in the
Yes.
eye. And later it becomes all fibrotic, and probably that inflammation induced because of the foreign body like IOL can lead to chances of cyclitic membrane and hypotonia.
Okay, sir.
Thank you, sir.
So I have a question for you guys. Can anybody answer what's Amsler's sign and where do you see it?
Fuchs uveitis, let's see.
There are
Fuchs at-
prominent vessels in the angle, so when you
Due
like
to
during paracentesis and all, it will bleed.
yeah.
Needn't be just
Yeah. And
paracentesis. Even if you do a
Gonioscopy.
gonioscopy, we can see
Gonioscopy.
vessels in
and
the
why does
angles.
it happen?
Breakdown of that vessels.
What vessels? They are just fragile vessels that are there, anomalous fragile vessels. And what is the choice of IOL in a patient with uveitis?
They say heparin coated IOL.
Heparin, yeah.
It causes less
Hydrophilic,
inflammation.
hydrophobic. Is it hydrophilic, hydrophobic?
Hydrophobic. Hydrophobic.
Phobic.
Ma'am,
Phobic.
hydrophobic.
Ma'am, hydrophobic.
Yeah, I hope you guys did not check on your Google. So, what are the two conditions with white eye? With
Fuchs
uveitis?
Fuchs uveitis.
Fuchs uveitis
Bessett's.
And
Fuchs
that's it.
uveitis and
and Bessett's.
Bessett's.
Pediatric?
JIA.
JI. And why
JI.
Behcet's hypopion is mobile?
Yes, it's more.
Why is it mobile? Why not ankylosing spondylitis?
Because in HLA-B27 positive cases, it have more fibrinous content. That's why.
Behcet's is a more sterile
Bessett's, there is
hypopion.
no fibrin
No,
substrate.
in HLA-B27, I'm telling that is a mobile.
Yeah.
Bessett's is sterile.
Behcet's
Sterile.
got a
This is
sterile hypopion and less fibrin content.
yes. So no adhesion takes place.
So, is Dr. Tulika available? Okay. Anybody? Which anti-glaucoma medication is contraindicated in cases of uveitis?
Prostaglandin.
Prostaglandin.
Prostaglandins.
Okay. And again, Dr. Tulika, if you can tell me this, what's the name of the clinical sign when a light beam passes through a aqueous protein and it gets scattered? Or aqueous cells? Sorry?
Ma'am, could you repeat the question, please?
Name the clinical sign when a beam of light is passing through your, basically you're putting a slit lamp, and how do you appreciate your cells and flare? What's that
Ma'am,
called?
Tyndall effect.
Yeah,
Due to
Tyndall effect or Brownian movement.
Yeah, ma'am. Ma'am, flare, aqueous flare.
Okay, and I have one more question. Why is leprosy more associated with anterior uveitis? Anybody?
Hint, hint is temperature.
Nerves, corneal.
Sir has given you a very open hint.
Iris vascularity.
What's happening?
Thickened corneal.
Okay, so by next intermediate uveitis class, you guys can answer why leprosy is predominantly only in anterior part, not the posterior part. So again, and one couple of questions I have for you guys.
The
Probably
bacteria, ma'am, it affects the mycobacterium affects iris and
why is my TB and lepre having a different presentation? Okay, sir has actually given an answer is in that.
Cornea is avascular.
You guys are only going to cornea. I'm talking about uveitis. Okay, you guys can read about it. It's a very simple thing. Read about it for intermediate uveitis class. So the next thing is, okay, if you have, usually when you are seeing an acute uveitis case, you kind of see in that eye ptosis. Why does it happen? Or in what kind of ptosis would you classify it into? Do you classify it into a particular ptosis? Anybody? What are the symptoms of, or what are the things that you notice in uveitis? All of you are given symptoms, signs in the start of the...
photophobia, blurring of vision, ma'am, meiosis.
So what do you see when you're seeing a patient's face? What do you see?
Ma'am, chin up.
Not all. Blepharospasm. Yes. So basically, there is chronic blepharospasm, and that causes your LPS fatigability. So this is not any neurological ptosis. It is not actually classified into ptosis. So this is LPS fatigability that causes or mimics ptosis. Yeah?
Okay, ma'am.
Thank you, ma'am.
Ma'am, this lepromatous bacteria, do they have this affinity, this affinity for cooler temperatures? Like they can't sustain. So I think they cause more inflammation in the anterior chamber.
Ma'am, so because of the iris is because of that iris vascularity also.
क्या हो रहा है? Temperature से what Shifa has said.
Affinity for lower temperatures. They can't sustain more high.
They prefer lower temperatures, cooler temperatures. So predominantly your iris vasculature and your ciliary vessels and all have lower temperatures. So it
Lower
only
temperatures.
resides at your anterior parts. That's why the leprosy presentation is more anterior.
Yes.
Okay. Which nerve is associated with ocular pain in uveitis? These are MCQs quite commonly asked in your exams.
Anterior ciliary nerve.
Anterior ciliary.
Yeah.
Anterior ciliary.
Trigeminal nerve, nasociliary branch.
Trigeminal nerve. Yes.
Nasociliary branch, trigeminal nerve. And what is one of the diagnostic skin tests that you do for Behçet's?
Pathology.
Pathology.
And again, another final question. If Dr. Avanik also can answer this, I would give her a chocolate tomorrow. What's ACADE?
Sorry, ma'am?
What's ACADE?
Anterior chamber associated immune deviation.
Oh, okay.
Yeah, so I think this is quite important. Ocular immunology for uveitis is very important. And for all the DNB students, as far as I know, like it's an important question. So probably you guys can have a revision before your intermediate uveitis. And it's important for corneal cases also, ACADE.
Yes, ma'am.
Yeah, that's it from my end, guys.
Okay, ma'am.
Thank you, ma'am.
So remember not to order everything in the anterior uveitis. Okay.
Yes.
In each and every test, do a tailored approach and go for the particular test only. Okay.
Yes, sir.
Okay. Saurabh sir?
Yes, very good class and good answers by everyone. Yes. I think you are the host, Akash, so you can